PRP has its pluses and minuses. Anti-VEGF has its pluses and minuses. I'm going to show you what the pluses and minuses are. And hopefully you can present that to each patient, take their values as we discussed with one of the talks yesterday, and decide what you want to do. Same disclosures. The first time people recognized that these anti-VEGFs like ranibizumab or bevacizumab or aflibercept might affect proliferative retinopathy was from an analysis at 1 year in Protocol I. And we looked at the eyes that had severe non-proliferative retinopathy at baseline. And we noticed that with sham, 19% of them improved by 2 or more levels in their diabetic retinopathy level. But with ranibizumab, 28% improved on photographs. Now, how did the laser group improve in terms of their level of retinopathy? Well, it's probably just some variability in looking at the photographs. And in terms of worsening, 8% worsened when we just added sham treatment with prompt laser, but only 1% worsened that got ranibizumab. So it suggested that we were not only treating the edema, we were having an effect on the appearance of the retinopathy. If we looked at complications of proliferative retinopathy when we were treating DME in Protocol I, in the sham group that got laser for their DME, 8% had a vitreous hemorrhage or needed PRP, 3% with ranibizumab. And so it suggested that the anti-VEGFs were having a good effect in addition on the retinopathy. This shows you the cumulative probability, if you had non-proliferative retinopathy, of having your retinopathy worsen. And the bottom line there is the ranibizumab with deferred laser. That's what we use for DME now. 13% had worsening of their retinopathy. The top line are the people that got focal grid laser and no anti-VEGF, by and large, for their edema. And 38% of them, their retinopathy worsened over 3 years. And that said, maybe you can avoid worsening of retinopathy. If you already had proliferative retinopathy, it had to be controlled. You couldn't enter this trial with proliferative retinopathy that needed PRP, but maybe you had a little NVE, or maybe you already had PRP and you had edema. It's the edema that got you into the trial, but the eligibility criteria said if there is PDR, it had to be controlled. And you can see here that about 200 of the eyes had PDR at baseline. And among the 4 groups there, what you can see is the top group are the eyes that got focal grid laser for their edema and their PDR worsened. How can you worsen? You could either worsen on photographs, a little NVD becomes bigger, you get a vitreous hemorrhage, you could add PRP, or you could go to vitrectomy. And so that happened 20% of the time among the eyes with proliferative retinopathy that got anti-VEGF, and it happened 40% of the time among the eyes that got focal grid for their edema. So it said maybe this can treat proliferative retinopathy. And it didn't require injections forever. So in the first year, the group that got ranibizumab with deferred laser, that second column from the right, that's how we treat right now, right? We do ranibizumab or we do anti-VEGF with deferred laser. And they got 8 injections in the first year, and they got 2 injections in the second year in the eyes with non-proliferative retinopathy. Yet I showed you that the retinopathy didn't worsen much in those eyes, even though they only got 2 injections in the second year, 1 injection in the third year. And with proliferative retinopathy, that subgroup with ranibizumab and deferred laser, they got 10 injections in the first year, only 5 in the second, 1 in the third. And I showed you that the proliferative retinopathy didn't worsen in 80% of that. It was far better, even though we didn't have to keep injecting monthly. So Ride and Rise showed the same results, but they gave monthly ranibizumab for 3 years. And Vivid and Vista showed the same results, but they gave aflibercept every other month after 5 injections through 3 years. So this tells you you don't have to maybe keep giving it. This is the Ride and Rise data with monthly ranibizumab there. And they had a 3-fold higher risk of worsening the PDR if they were in the control group. Then those bottom lines are 0.3 and 0.5 ranibizumab. So we looked at this in Protocol T as well. And we looked at the eyes that had non-proliferative retinopathy or the subgroup that had severe non-proliferative retinopathy. And we looked at the eyes that had proliferative retinopathy. And we saw the same thing. Very few people worsened over 2 years. That's very little worsening. That's probably just what you would see by just regrading the photographs in terms of worsening of retinopathy. And even if we just look at the eyes with moderate to severe non-proliferative retinopathy, there's only a little worsening there that we can see, especially with aflibercept or ranibizumab. If they had proliferative retinopathy, they still worsened, but very few worsened substantially. And you can see that we had a large number of eyes to look at. Now, if we look at the improvement, that was worsening. If we look at improvement of retinopathy, and look at the eyes that had non-proliferative retinopathy at baseline, you can see that about a third of them improved by 2 years when they were being treated for their DME. And that was sustained, not completely, to 2 years. They're getting less injections, an average of 5 injections in the second year. And even if we look at severe non-proliferative, it's the same story. It stays about the same. Now, if we look at the eyes that had proliferative retinopathy at baseline, here you can see that they're also likely to improve. How do you improve? You go from having NVD to not seeing it. Or you go from having NVE to not seeing it. You can see that that resolution was a little greater with aflibercept than ranibizumab or bevacizumab. And that was sustained to 2 years in terms of people that had proliferative retinopathy and improved. And this gave us the idea that maybe you could just treat proliferative retinopathy with anti-VEGF. Now, I wouldn't necessarily say that aflibercept is better than ranibizumab or bevacizumab, even though we see these differences at 1 year, because at 2 years they're still there for aflibercept versus bevacizumab or ranibizumab, but it's very small numbers. So that would have to get compared in larger studies. But the idea was, let's take people that have proliferative retinopathy, whether they have edema or not, and let's try it compared to PRP. Now, people were angry about that sometimes. They said, wait, you have a great treatment. You've been doing it for 40 years. Why do you have to improve on it? I'll tell you why I have to improve on it. About 100% of the people, just about 100%, lose some visual field when you put in PRP. I don't know that you would get that if I used anti-VEGF. I know that some people go on to needing vitrectomy when we do PRP. We just have cases every week that they come in, and we did PRP, but they have a vitreous hemorrhage that won't clear, or they have a traction detachment that won't go away. And I have people that have proliferative retinopathy like this patient, who has no edema, and then we do PRP, and a year later they walk in and their proliferation looks fine, but they have edema that I have to start treating. So we published these results in JAMA just in 2015 to look at what happened. Now let's just take the case where you're already giving anti-VEGF, okay? Let's take this case. So this person's 60 years old. Their vision is 20/50 in the left eye. Look at that lipid, weren't we talking about that? There you go. And they happen to have some pre-retinal hemorrhage. That's from the NVE. They have some NVD. You may not see it well in the photograph here. It's there between 12 and 3 o'clock. And there's some pre-retinal hemorrhage above the nerve, probably from some traction on that NVD. So they have diabetic macular edema. The OCT was thickened, 450 microns. And they have proliferative retinopathy. So let's just take the DME from the previous talk. You're going to treat them 6 times with that, right? The question is, while you're doing that, do you have to add PRP? That was the standard care before we had the results of the study, that you would add the PRP. What happens if you don't add the PRP? Are they in a lot of trouble? So we looked at that because we said we have 2 choices here. You can give PRP for the PDR, you can give anti-VEGF for the DME, or if you're already giving the anti-VEGF for the DME for no extra charge, you can have it go in there and maybe treat proliferative retinopathy. That was the question. Now I'm going to show you why this is a reasonable alternative. It doesn't mean you have to use one or the other. It's just a reasonable alternative. Many people would be afraid, maybe you would, of not giving PRP to this patient. But we discussed it with them. We said, I'm going to need to see you every month for the first 2 years. And then we might be able to stretch it out after that, but I've got to treat your edema anyway. I've got to see you every month anyway to treat that. And I might have to do laser periphery, but we're going to try with that. So we randomly assigned those cases in protocol S to either get anti-VEGF and PRP or anti-VEGF alone, and they had both. So in the overall trial, we had about 400 eyes, but a quarter of them had what I just described. A quarter of them had DME with vision loss. That's what I just showed you. That person was 20/50 with all that lipid and edema there. They had DME with vision loss, and they had proliferative retinopathy. And those eyes were randomly assigned in the ranibizumab group to just ranibizumab. And in the PRP group, they were assigned to ranibizumab for the DME and PRP for the PDR. Combination treatment. Remember what we said about combination? You add corticosteroids to anti-VEGF for edema left over, it doesn't go away. You add laser to anti-VEGF compared to anti-VEGF alone, it's not better. Guess what? We're going to compare. Which has fewer injections prior to 2 years? Remember, they both have edema that we're treating. 14 versus 9. They win. Okay, so if it's just about the total number of injections you have to do, you want to do PRP and add anti-VEGF, okay, for the edema. How many eyes received PRP though? It's not just anti-VEGF that they got, it's PRP. 12% got PRP. Why did they get PRP? Because they were given anti-VEGF, then maybe they had a breakthrough vitreous hemorrhage, it never cleared, and they went to surgery, they had vitrectomy, they had endo laser, that counts as PRP. So in fact, 4 out of 5 of those cases in the anti-VEGF group were 4 cases that went on to vitrectomy, and they got endo laser. Only 1 got it at the slit lamp. On the other hand, 100% of the eyes assigned to PRP got PRP, okay? So they win. How many get focal grid? When do you get focal grid? You know now, after 6 injections, if there's still edema, you get focal grid. That was a tie. 20% of the eyes had residual edema after 6 injections where we added laser. Doesn't mean it stayed away after 6 injections. Sometimes it came back and we had to resume injections, but as long as it went away once it stabilized, we would not add laser. If it was still there, we'd add focal grid laser. But also, who has better visual acuity? It's not just about injections, it's not just about PRP. Who has better visual acuity? The top line are the people who got anti-VEGF for their DME, and the anti-VEGF was used to treat their proliferative retinopathy. They gained 8 letters. The bottom line are the people that got the combination treatment. Once again, combination wasn't better, okay? So even though the blue line got anti-VEGF for their DME, it failed to have as good effect on the vision, or the PRP blunted the ability of the anti-VEGF to improve the vision. Now the confidence interval, because these are small numbers, crosses 0, so we're not certain that there's a difference, but we also had pre-planned looking at the area under the curve. The time spent with improved vision was better in the anti-VEGF group, and we're more confident about it. Are we 95% confident? No, but we're more confident about it. These p-values are adjusted for multiple looks at the data, and that 0.08 suggests it's likely better. It's not definitely better, it's likely that the vision's better. And in fact, this was then done in the Clarity study out to 1 year. These are 2-year data. And using aflibercept, they did show that the vision was better. There's a weakness to that study in that they didn't add anti-VEGF if those people developed edema, but they did show a better vision for the anti-VEGF group than the PRP group. But just concentrating on this, it's likely that the vision's better. So here, it goes to the left-hand side. I couldn't fit it all in the box there. That it favors anti-VEGF alone. So think about that case again that I showed you. When you see that patient, if you say, I want to give you anti-VEGF and I can't stand looking at all that pre-retinal hemorrhage and NPD, I want to give you PRP, make sure you also say, and on average, your vision will be worse than if I don't give you PRP. Think about that over 2 years, okay? Which has less visual field loss? Well, what we learned was that there's almost no change in the mean sensitivity when we combine the Humphrey 30-2 and 60-4 visual fields compared with if we give PRP, there's substantial loss of the visual field. Now, they don't report it. We asked them a questionnaire. We said, how's your peripheral vision at baseline and at 2 years? And they didn't report any differences. That doesn't mean that it's not bad. It just means that when you ask them what they perceive, they don't see it. Think about somebody who can see their hand here, and then they lose their peripheral vision. They don't see the hand until it's here, off to the side. They just don't notice that. I'd rather have this peripheral field and this peripheral field. It's just we don't have a questionnaire yet that maybe reflects whether that's important or not. I'd rather have that peripheral field there. So this group wins again. So here you go. Next time you see a patient like this, you can say, I don't know how you're going to do as an individual, but I know if I treat 100 people like you, I could do PRP for the PDR, it's very viable, it works. I can do anti-VEGF for your DME, very viable, it works. Or I can do anti-VEGF alone. And if I give you anti-VEGF alone, you'll need more injections than if I give you PRP and anti-VEGF. But you won't lose your visual field. your visual acuity on average will be better than if I give you the other treatment. And so that's why I recommend that. What happened with this patient? That's what we did. Here they are 3 years later. This is not atypical. This is the typical outcome that we learned. We didn't know it would happen. We were scared to death about this. We watched very carefully. They ended up 20/20, the PDR resolved, the DME resolved. There's the macula. A little fibrous wisp of tissue there, but no fibrous nodule like we saw with lipid. That's the average. They needed 9 injections in the first year, 7 in the second, 5 in the third. But for that price, we got the vision to improve, the high-risk PDR resolved, the DME resolved, no PRP, no visual field loss, and the injection need is declining over time, but they may need it indefinitely to take care of that, just like they need to take insulin indefinitely to take care of their diabetes. Well, it wasn't just the eyes that had DME that had better vision. Even the eyes without DME had better vision on average over 2 years. And if we look at the visual fields for that group, we can see that it was better in the ranibizumab group than in the PRP group. The other thing we learned about the group that did not have DME is we said, how often do you get DME with vision loss? So they walk in with proliferative retinopathy, and you could do anti-VEGF for the proliferative retinopathy, or you could do PRP for the proliferative retinopathy, but now they have no DME. Who is more likely to develop DME with vision loss over 2 years? Not all at once from the PRP. I mean over 2 years. So 30% of the eyes that got PRP developed edema in the macula with vision loss. Having proliferative retinopathy with no edema still means you have a diseased macula. And unfortunately, 30% of these eyes developed edema with vision loss by 2 years where they needed anti-VEGF anyway. 9% of the eyes that got anti-VEGF needed it. And that's because we did 6 injections in the first 6 months. But the median was only 1 injection in the second 6 months and 3 injections in the second year to manage the proliferative retinopathy. So it gave that sick macula a chance to develop edema, even in the eyes assigned to anti-VEGF. So 10% of those eyes developed it, but still the odds are greater that you'll need treatment for DME if you do that. So we'd rather consider anti-VEGF as a potential better thing. It doesn't destroy the visual field and it gives you less chance of getting edema there. How about other complications? Well, the chance of needing vitrectomy, usually for non-clearing vitreous hemorrhage or traction detachment, happened 5% of the time in the anti-VEGF group. It happened 15% of the time, 3 times as much in the group that got PRP. So just remember that. This is good PRP that they gave. These were by experienced people. And about 1 out of 6 to 1 out of 7, unfortunately, over 2 years, have either a non-clearing vitreous hemorrhage or a traction detachment. They need to go on to vitrectomy. And it's more frequent if you use PRP than if you use anti-VEGF. So just keep that in mind. It means that they both work, but that there's a difference. We looked in detail at a composite outcome of worsening that we called vitreous hemorrhage on the bottom there, retinal detachment, or iris or angled neovascularization. And that happened a lot with ranibizumab, mainly from vitreous hemorrhages. But it happened even more often in the PRP group. The hazard ratio says you have about a 30% greater chance of having that happen if you give them PRP. And even the eyes without DME, the difference was even greater, 30% versus 45%. Another 50% of the eyes developed a complication of vitreous hemorrhage, retinal detachment, or angular iris neovascularization when you gave them PRP. Most of them are vitreous hemorrhage, but it's more likely to happen if you give PRP. Here we broke them down by the vitreous hemorrhage, by retinal detachment, which is not as frequent but more common in the PRP group, and vitrectomy, more common in the PRP group. So you just have to keep that all in mind, that it's more likely to need this intervention in the eyes that get PRP. The Clarity trial looked at this as well, but just in eyes with no edema. They didn't treat those eyes with edema that developed with anti-VEGF, so it was just PRP versus anti-VEGF for a year, and they showed better outcome and fewer hemorrhages in the eyes that got aflibercept. So the conclusion was that either with ranibizumab or aflibercept, at least through 2 years, you might get better vision outcome. There is better visual acuity over 2 years. There's less DME developing if you started with no DME, fewer complications. I didn't talk about the cost effectiveness. It was only cost effective when there was DME there and you were treating with anti-VEGF anyway. But in all the eyes, there was less visual field loss. Now, they do have to come back for follow-up, but they don't have to come back for follow-up just with anti-VEGF. They have to come back for follow-up if they get PRP. I already told you that 30% of the eyes develop DME with vision loss. You need to find out 1 out of 3 people who that's going to be. And I told you 15%, 1 out of 6 or 1 out of 7 need vitrectomy. So you can't just do PRP and have them run away. Compliance is critical with both of those because of those issues. So what's the optimal treatment in this person? I think it's worth considering anti-VEGF. Now, we just showed the 5-year results of those eyes. That just came out about a month ago. And what we learned was that these results were sustained out to 5 years, with one exception, and that is in terms of the number of treatments. We had to keep treating, on average, 3 times every year in years 3, 4, and 5. And the visual field went down a little bit in the anti-VEGF group, and that worried us. Gee, are we causing infarction or ischemia? But probably due to the PRPs that were added in the small group that went on to vitrectomy, they got endolaser, or a little vitreous hemorrhage. So we would say that the results to 2 years likely fall out to 5 years, and we just think that this is a viable treatment. And I'm going to end there, and I'm going to take questions afterwards, because we're going to have lunch after you sat here all day. Thank you very much. All right, I went a minute over. Sorry. Oh, you want to take questions? Okay. All right, I'll take a question or two. Go ahead. The grading of the diabetic retinopathy. Yeah. Yeah, no, I got the question. So the grading of the diabetic retinopathy could only be looked at in the anti-VEGF group. Why? Because when you put PRP in, you can't really grade the photographs very well anymore. In the anti-VEGF group, the retinopathy in many of the eyes got better by 2 or more levels. So it went from, let's say, level 65 to level 43. In 20% of the eyes, at 2 years, there was no longer any retinopathy seen that was persisting to 5 years. Gone. They started with PDR, gone. So not most, but many of them improved, and 20% had no retinopathy remaining.
2 questions. One, were any eyes with the fibrous proliferation included for the anti-VEGF in this trial?
Yes. So we included eyes that had fibrous proliferation. They were high-risk PDR eyes. It was about 25% of the eyes had some fibrous proliferation. Some of those had extramacular traction detachment. The only exclusion criteria is if you had a traction detachment involving the macula or threatening the macula, but otherwise not. And when we looked at those eyes, and this was just reported in the 5-year results that came out last month, when we looked at those eyes, you were more likely to go on to traction detachment requiring vitrectomy if you got PRP than if you got anti-VEGF. So you did go on in some of them that got anti-VEGF, but it was more likely if you got PRP. So we recommend to consider either one, but your risk of traction detachment progressing is greater if you give PRP.
And second one, how do you explain the peripheral treatment that the retina is already ischemic?
It works and it doesn't get worse, so that we must have a lot of redundancy to the amount of vessels we need to have it still work. So it worked at baseline, and for most of them, it didn't change over 5 years. There were some, as I said, that changed between 2 and 5 years, not between 0 and 2, between 2 and 5. And we're still analyzing this because the 5-year results just came out. So far, what we reported was that it appears that it's just the eyes that got some PRP with endolaser that had a drop in their field, as well as some eyes that, when we measured it at 5 years, had some residual vitreous hemorrhage that reduced the field. So it must mean that all that peripheral non-perfusion and whatever function is working peripherally, we didn't know this, now we know, doesn't deteriorate at least over 5 years. 20 years? I don't know yet, but at least over 5, pretty good. So that's why we would consider this, rather than wiping out the field, not wiping it out, but greatly reducing it when you do PRP. You're not going to have that happen in most of the eyes unless those eyes go on to vitrectomy and you add it. Now we're questioning, should we even add it after our vitrectomy? Should we be adding endolaser at the end? Boy, it's sure hard not to do it, but it's worth considering.
How do you recommend following up the anti-VEGF group for development of PDR, let's say 2-3 years down the line? Do you do angiography? Do you wait for hemorrhage to occur? Do you wait for clinically significant large NPDs to form? How do you follow these up?
Yeah, so since it really varies with each patient, we told the investigators they could follow it however they want. And some of them just followed by looking in, some follow with serial photographs, some follow with serial angiograms. Since you're going to start with 6 injections, and then what we do is we stop injecting, even if there's residual NV, sometimes it's all gone, sometimes it's just sitting there, and we only resume if it begins to worsen. It worsens in about half of the eyes each year, so half of the eyes it didn't worsen. So each year in year 2, 3, 4, and 5, about half of the eyes needed injections again. We typically did it 3 more times because we wanted to be certain that it wasn't worsening any further. So since it's not an OCT that's as objective as our looking in at NV, we would just look in. And it ended up that half of the eyes in year 2, not the same half in year 3, not the same half in year 4, not the same half in year 5, but variably needed 3 more injections, but that's all they needed to keep it under control. And so we would do it however which way you could do it. What I typically do is I try to get a wider field, black and white photograph. The black and white, red-free photograph shows the very fine vessels better than on color photograph most of the time. And I just use that to try to compare with the drawing. I typically don't use fluorescein, but again, we're not looking for fluorescein leakage, we're looking for existence of the vessels to do that. So you could do it just by looking in and realize that about half of the eyes will have something, half of them won't. You'll have to do like 3 more injections, and then that should take care of it most of the time. Again, not everybody. Some went on to non-clearing vitreous hemorrhage needing vitrectomy, but most of the time. So I would consider that if you're going to consider this treatment. They both work. PRP is fine, but this is, they each have their pluses and minuses. Okay?
Did the capillary non-perfusion areas in the periphery, those who began with treatment and those who were followed up for them, those the angiograms done, did it make a difference to those areas?
So we didn't do angiograms as part of the protocol, so we don't know from this trial.
But the subset of them, like you said, you told the investigators that you can follow them up.
Correct. So they would have those in their charts, but we didn't collect them as part of the study. Yep.
For the management of the PDR, whether you're using
ranibizumab, but for the other classification of diabetic, we also learned that the Rani and also the bevacizumab have not inferiority. So can we use befa for the PDR?
Yeah. We don't know how they do with bevacizumab, so that's an unknown. I would hope that it would work the same, but we just don't know. So we know that aflibercept likely works the same because the Clarity trial looked at that, and this was with ranibizumab. But if bevacizumab doesn't avoid vitrectomy as often, if it doesn't prevent the edema from working as well, then you wouldn't do it. If that's all you had access to, I don't know what I would do between bevacizumab and PRP because I don't know the results of bevacizumab. So I think I would likely just choose PRP if I only had access to bevacizumab. But if I have access to either aflibercept or ranibizumab, I would at least strongly consider using that to treat the anti-VEGF alone or anti-VEGF. The PDR alone or the PDR even if it has DME. I just don't know what to do yet with bevacizumab because it's scary. What if it doesn't stop it as often? Then you've disadvantaged the person compared with PRP. I know how PRP works. It works really well.
Prof, thank you, very good talk. There is some concern that post-vitrectomy, the half-life of these anti-VEGFs in the eye are reduced. Do you have any advice for post-vitrectomy patients?
Yeah, we looked at that in Protocol I, where we allowed people to have DME at baseline even if they had had vitrectomy for some reason. It might have been proliferative retinopathy, it might have been an epiretinal membrane peel. And it was only about 25 eyes. But in those 25 eyes, the response seemed identical to the other 300 eyes that didn't have vitrectomy at baseline that got ranibizumab. So 25 eyes got ranibizumab, had vitrectomy, 300 eyes didn't have vitrectomy, got ranibizumab. The treatment effect compared with laser seemed about the same. The number of injections seemed about the same. So it's likely that that doesn't affect it. That probably makes sense because what happens to the anti-VEGF agent is it doesn't really sit around in the vitreous. It actually goes into the retina tissue and binds with the VEGF that's there. It's an anti-VEGF binding, not with VEGF that's hovering around in the vitreous so much, but the VEGF that's in the retinal tissue causing the edema or causing the proliferative retinopathy. So I would treat an eye that had vitrectomy that needs anti-VEGF for edema the same as if it didn't have a vitrectomy. And that was published a few years ago in the network trials.
Thanks, Prof. That's a good answer. But in relation to proliferative disease, do you think that's similar? Do you think we can extrapolate, or do you think we need more data?
I think you can extrapolate because we did have some eyes go on to get vitrectomy here, and then we continued the course. We would give them anti-VEGF if it worsened, and we don't have evidence that they were going wildly out of control. But we almost all got endo laser at the time of the vitrectomy.
Thank you.
Okay, thank you very much. Okay,
Thank you.
Anti-Serve, please come back on time at 2:15 because we have 3 more talks today. Thank you.